From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Mary McDermott, Deputy Editor of JAMA and Professor of Medicine at Northwestern University Feinberg School of Medicine. Today, I'm joined by Dr. Prateek Sharma. Dr. Sharma is Professor of Medicine at the University of Kansas School of Medicine and at the Veterans Affairs Medical Center in Kansas City. Dr. Sharma is also a practicing gastroenterologist. Dr. Sharma, thank you so much for being with us today.
Thank you, Mary. It's my pleasure to join this JAMA podcast.
Your review covers the diagnosis and management of Barrett esophagus, and I wonder if we could start by having you tell us, what is Barrett esophagus?
Yes, a great start for this podcast is defining the disease. Normally, the esophageal mucosa is lined by squamous cells, so that's on endoscopy appearing white in color. In patients with Barrett esophagus, this is lined by columnar mucosa, which is typically the type of mucosa that you see, for example, lining the stomach. It's a metaplastic change in which the squamous cells get replaced by columnar cells, specifically intestinalized type of cells. When this change happens, it's called Barrett esophagus. So it's a combination of an endoscopic recognition, which shows a change in the color of the lining, and then obtaining biopsies from this columnar lining, which documents the presence of intestinalized type of epithelium.
Do we know why this happens?
It's probably due to a multitude of factors. One of the strongest risk factor or why this happens is because of chronic gastroesophageal reflux disease. So the reflux of contents of the stomach, which contain mainly acid, but also bile and other secretions, when they reflux from the stomach into the esophagus, causes inflammation and can start this cascade of changes as described. There are additional factors also which may be playing a role, such as age, gender, cigarette smoking, obesity, and the diet that a person consumes. So with a combination of those, you could be at a risk for Barrett esophagus.
So can you talk a little more about the relationship between gastroesophageal reflux disease and Barrett esophagus? And obviously not everybody with GERD gets Barrett esophagus. So who should we think about as being at highest risk among people with GERD, for example?
Reflux symptoms or GERD is very common in the general population, whereas only a minority will be at risk for developing Barrett esophagus. So subjects who have had reflux symptoms for 5 or greater years, we have been able to show that male gender is associated with Barrett's esophagus, age greater than 50, smoking, obesity. So if you have reflux, doesn't mean that you will get Barrett esophagus. Only about 2 to 8% of folks who have chronic reflux, as I said, with 5 or greater years, will be at risk for Barrett esophagus. So if you flip it around, the vast majority of subjects who have reflux symptoms will never develop Barrett esophagus during their lifetime. So if you have those long-standing reflux symptoms, along with some of these risk factors that may put you at a higher risk for Barrett esophagus. And that's when you need to have that conversation with your physician, whether you need to be screened for Barrett esophagus or not.
How is Barrett esophagus diagnosed? And you mentioned screening a moment ago, and perhaps you could talk about, should any individual be screened?
So let's start with the screening one, because we just mentioned that. What guidelines are recommending is that if you are a male over age 50 and you've had reflux or chronic GERD for 5 or more years, and in addition other factors such as smoking, obesity, or you consume a diet which is high in meats and fast food, those put you at a higher risk for Barrett esophagus. And so if you have reflux plus any additional risk factor that I just mentioned, that's a subject who could be considered to be screened. Now, the screening would have to be done by a gastroenterologist or an endoscopist. So again, going back to the diagnosis or the definition of Barrett, when we perform an endoscopy looking for Barrett esophagus, what we first try to identify is there any change in the lining of the esophageal mucosa from the normal squamous to the abnormal columnar type of mucosa. This is a change which can be recognized endoscopically through our endoscopes. If we see that change, then we obtain biopsies from that area. Now we are looking for a special type of epithelium which puts patients at a higher risk for neoplastic progression, and that is called intestinal metaplasia. So you require a combination of an endoscopy plus a confirmation with biopsy. And one of the things, obviously, we haven't mentioned so far, the interest in Barrett esophagus is because it is a precancerous condition for esophageal adenocarcinoma.
Great. And I want to get back to that in a moment. But first, you've mentioned a couple of times that people with at least a 5-year history of reflux should be considered for screening. Is that people with symptomatic reflux, or if a patient has been on, say, a proton pump inhibitor and well controlled for more than 5 years, would that person also be considered, or is it only someone with continued symptoms?
Anyone who is having symptoms or is having controlled symptoms. Now, of course, if you have uncontrolled symptoms, either with taking medicines or being partially treated, that would be an indication for getting evaluated by your gastroenterologist with or without endoscopy for a separate reason. But if you are taking a proton pump inhibitor or an acid suppressive medication and you've been on it for 5 years or longer, you're required to take it every day. And that's controlling your symptoms. It means the reason you're taking it every day is because if you didn't take it, you would get symptoms. So that would be an individual who would be at a risk for Barrett esophagus, and that individual should be considered for screening.
We've talked about the fact that Barrett esophagus is important because in some patients, it can progress to esophageal adenocarcinoma. So what proportion of people with Barrett esophagus will progress, and who's at highest risk for that progression?
The good news here is that the absolute risk of progression in patients with Barrett esophagus to esophageal adenocarcinoma is extremely, extremely low. And I want to highlight this because patients who are diagnosed with this condition start getting really concerned and scared that they're going to die from esophageal adenocarcinoma tomorrow or in the next few months, and that's not the case. In patients who don't have dysplasia or any early neoplastic change in their Barrett's esophagus at baseline, their risk of progression is at a range of about 0.2 to 0.5% annually, and their lifetime risk is about 3 to 4%. So the overall risk is quite low. One of the strategies that I employ with my patients, specifically the GERD patients, is I'll tell them that GERD is extremely common in the population. Barrett esophagus within GERD patients is less common, and cancer within the Barrett population is extremely less common. So this just gives them a perspective that they're going from a high prevalence disease to a low prevalence disease, so that they are not really just losing sleep or having anxiety over this condition. Now, the second question you mentioned is progression from Barrett esophagus to esophageal adenocarcinoma. Now, just to step back, I've used a couple of terminologies already about dysplasia and cancer. So it's assumed that Barrett esophagus, which will be non-dysplastic, progresses through stages of dysplasia, and the stages of dysplasia are low-grade dysplasia, high-grade dysplasia, and then eventually into esophageal adenocarcinoma. And even within esophageal adenocarcinoma, it can be early esophageal adenocarcinoma and late stage or invasive esophageal adenocarcinoma. So that sort of is the entire spectrum of progression. Again, the vast majority of patients, 90% or so, will remain in the bucket at the baseline, which is non-dysplastic Barrett's esophagus. So that's the good news, that that's the vast majority, and the others will have progression of varying degrees. Even in this population, the risk factors that we know of are, as the age increases, male gender, history of smoking, and if you have low-grade dysplasia. All of these factors start increasing your risk of progression to esophageal adenocarcinoma. Added on to this is another strong risk factor for progression, which is the length or the extent of the Barrett esophagus. So let me just spend a quick minute here explaining what I mean by that. Barrett esophagus can vary from a length of 1 centimeter up to 18, 19, 20 centimeters. The average length in cohort studies has been reported to be about 4 centimeters or so. This is a length which we measure at the time of endoscopy. So analogy is colonoscopy and diagnosing colon polyps. The gastroenterologist will probably tell you after that, well, I found 1 polyp or 2 polyps, and the size of the polyp was X centimeters. Similarly, for Barrett esophagus, we measure the size or the extent or the length. And the reason we do that is because that's also linked to the rates of progression. So those are some of the risk factors if you have Barrett esophagus and you have these additional factors that will put you at a higher risk for progression to esophageal adenocarcinoma.
So can you talk a little bit about surveillance and how one monitors a patient with Barrett esophagus?
Just for our listeners and specifically the trainees, Mary's used 2 terms already in our discussion. One is screening, which is when you're trying to identify a disease in a given population. And then in this situation, it would be diagnosing Barrett esophagus. Then when you've made that diagnosis on screening, you enroll that patient in a surveillance program. And what that means is now you've made the diagnosis of the disease, you're looking for progression to a more advanced disease, and that would be surveillance in patients with Barrett esophagus. Surveillance is based on the baseline degree of dysplasia that you had, and that goes back to our point earlier about the different grades of dysplasia. If you have no dysplasia at baseline, then you undergo endoscopy every 3 to 5 years. Now, why that range? It's 3 years for those individuals who have a Barrett length of 3 centimeters or greater, and 5 years for a length which is less than 3 centimeters. If you have low-grade dysplasia, those patients undergo endoscopy within the first 6 to 12 months. And the reason being, you want to rule out an advanced grade of lesion. By that, I mean that whenever we see dysplasia, the concern is, of course, whether it's low-grade or high-grade dysplasia, but more importantly, have you missed esophageal adenocarcinoma? Because we talked about that continuum. And so once patients start getting into the dysplasia grade on biopsy, I'm always concerned, am I missing cancer? And that's why these patients with dysplasia will come back within the first 6 to 12 months for rebiopsy to make sure there's no advanced grade cancer. If it's confirmed as low-grade dysplasia, which requires confirmation by a second pathologist looking at those slides, and the reason being that there is an inter-observer variability amongst pathologists for calling dysplasia. And this is, again, not just specific for Barrett esophagus, but we see this dysplasia issue in other areas as well, such as inflammatory bowel disease, cervical dysplasia, etc. So we need to have another pair of eyes confirming that it truly is dysplasia. High-grade dysplasia is an area that we start getting concerned about because it's very close in the continuum to esophageal adenocarcinoma. And if a patient is agreeable, we go over the options for treatment for high-grade dysplasia, and guidelines currently recommend that endoscopic treatment is the way to proceed for treatment for patients with high-grade dysplasia. And we'll talk about treatment in a little bit, but that goes into the surveillance aspect, that you repeat biopsies to confirm, and then you stop surveillance because then you need some sort of a treatment in that patient population. So that, Mary, is sort of how surveillance is based in patients with Barrett esophagus.
So let's talk about management beyond the surveillance and tell us about the treatments that can prevent progression, or are there any treatments that can prevent progression of Barrett esophagus to esophageal adenocarcinoma?
Beyond surveillance, the first is treatment for the underlying reflux symptoms. And this is achieved by using proton pump inhibitors. And this is for treatment of underlying symptoms that the patient has. Now, progressing on this type of treatment, always a question is, will the use of proton pump inhibitors or other agents such as aspirin, NSAIDs, statins, will they also have, quote unquote, a chemopreventative role? And the short answer is probably not. And guidelines do not recommend that you take any of those additional medications to prevent progression as a chemopreventative role. Having said that, there is some low level of evidence for all of those agents, but specifically for proton pump inhibitors in a systematic review meta-analysis, but again, based on case control studies, which showed that individuals with Barrett who were taking PPI as compared to individuals with Barrett not taking PPI showed a reduced rate of progression. So the guidelines recommend that you treat patients with proton pump inhibitors to control their symptoms, and that there may be an added advantage that the use of proton pump inhibitors may have an impact on progression. However, the evidence for that is not conclusive. On the other hand, the guidelines do not recommend that you use any of those other medications I mentioned, specifically aspirin or NSAIDs or statins, routinely, that in your practice, and you recommend patients to take that. So that's as far as medical therapy is concerned beyond surveillance. The next area which has made a significant impact in patient management and care over the last decade or so is endoscopic treatment. And that is endoscopic treatment to prevent progression to invasive esophageal adenocarcinoma. So guidelines recommend that if you have a patient with high-grade dysplasia or early esophageal adenocarcinoma, which would be mucosal esophageal adenocarcinoma, which has not invaded as yet, those subjects would be candidate for endoscopic treatment. Now, endoscopic treatment has been shown to prevent progression to invasive esophageal adenocarcinoma. So that would be treatment or management strategy for patients with high-grade dysplasia as well as early esophageal adenocarcinoma.
Does all esophageal adenocarcinoma begin with Barrett esophagus?
The short answer is that probably. Studies have shown that the vast majority of patients have associated Barrett esophagus. However, on the flip side, the majority of patients with Barrett esophagus are not in surveillance programs. So I'm answering your question two ways, Mary. One is your question, is Barrett the only precursor lesion, for example, for esophageal adenocarcinoma? And the answer is that in the vast majority, and by that I mean in more than 90%. Where does that evidence come from? It comes from esophagectomy studies done in the past. in which if you take patients with esophageal adenocarcinoma undergoing esophagectomy with or without a history of Barrett esophagus, in the esophagectomy specimen, you will find Barrett esophagus in the vast majority. So that question is that the only precursor lesion? The other question, which I think from a healthcare perspective is a more important one, is that studies have shown that patients who get diagnosed with esophageal adenocarcinoma during endoscopy, very few of those have been in a surveillance program, highlighting the issue that the vast majority of patients don't get screened, don't have a diagnosis of Barrett esophagus, and therefore are not in surveillance programs. So the push in terms of research now is, should we screen more? Should we look at ways to improve risk stratification so that we can capture that pie of patients who are developing esophageal adenocarcinoma directly without having a prior diagnosis of Barrett esophagus?
Well, thank you for this really informative discussion of the diagnosis and treatment of Barrett esophagus. Is there anything else that you would like to add that we haven't covered?
Yes, just a couple of very quick points. Randomized controlled trials haven't been conducted. Also, we are struggling in this area with risk stratification. There have been some attempts at risk stratification going beyond the length of Barrett esophagus. There is a score which has been initially validated and is being revalidated. It's called the Progression in Barrett scoring system, in which, based on risk factors that individuals with Barrett esophagus have, you can assign them a score. And based on that score, you can decide even further whether you can have surveillance intervals which span not just 3 to 5 years, but as, for example, for screening colonoscopy, we have gone to 10 years. So my hope in the future is that we will have these validated risk stratification scores that certain individuals who are at an extremely low risk of progression could get an endoscopy. That surveillance interval could be lengthened even further from 5 to 10 years. And those are all in the works. So I think the future appears quite bright in this field. And it's something that hopefully within the next several years, we will have tailored and a personalized care approach to individuals with Barrett esophagus.
Thank you so much, Dr. Sharma, for that really informative summary. I've been speaking today with Dr. Prateek Sharma about his JAMA review on the diagnosis and management of Barrett esophagus. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Jesse McQuarters, Daniel Morrow, Lisa Hardin, Audrey Foreman, and Mary Lynn Ferkaluk. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.